Hello, listeners! This is Federica
and Alexandra from Drug Safety Matters.
Before we resume our episode, we wanted to announce a new podcast feature. It's called Fan Mail, and it makes it even easier for you to get in touch with us.
That's right. All you have to do is click the link at the top of this episode's show notes. That will open a new text message directly to the show.
All text messages are anonymous and will be sent to our podcast platform. You can use this feature to ask us questions,
suggest new topics,
or just say hi.
We can't wait to hear from you. Now on with the show.
Welcome to Drug Safety Matters, a podcast by Uppsala Monitoring Center where we explore current issues in pharmacovigilance and patient safety. I'm Fredrik Broneus, and today I'm looking forward to learning more about drivers of data quality in the reporting of adverse drug reactions. We often talk about the challenge of underreporting and the large proportion of adverse events that never reach the ears or desks of pharmacovigilance assessors. But the quality of reports is also crucially important. And this is why today's guest, Henry Zakumumpa at Makerere University in Uganda, decided to explore drivers of data quality in the reporting of adverse drug reactions. He did this in a recent qualitative study where he and colleagues interviewed healthcare professionals and patients at HIV clinics in Uganda. Henry now joins us online from Kampala to tell us about the results from the study and what we can do to improve data quality in the reporting of adverse drug reactions from healthcare professionals and patients. Welcome back to Drug Safety Matters, Henry. We're so glad to have you on the show again, and this time joining us from Uganda.
Yes, absolutely. It's a pleasure to join Drug Safety Matters again, and it was a pleasure to be in Uppsala a few days ago.
That's right. You were in Uppsala a few days ago for the ISOP mid-year conference, but we didn't manage to meet up then. So it's been 3 years now since we last had the pleasure of having you on the show, and that was back in April 2022, and the topic then was the safety of HIV medications. And HIV medication safety is also part of today's discussion, but from a slightly different angle. But before we go into that, I was wondering if you could tell us a little about your research at large. What are your key research interests, and what drives you as a researcher?
Thank you, Frederick, for this question. What really drives me is the overwhelming HIV epidemic in Uganda. Uganda has one of the highest populations of people living with HIV/AIDS, so we have a huge HIV burden. And I've lost people to HIV. My cousin sisters and my maternal aunt died out of HIV. So I have devoted myself to doing all I can to contribute solutions towards responding to HIV epidemic in Uganda.
Yeah. And what got you into pharmacovigilance? Because that's quite a special field as well.
That's a good question, actually. But what happened is what attracted me to pharmacovigilance was, I think it was 2019. Uganda at the time was rolling out a newer HIV therapy called dolutegravir or DTG, and patients were being transitioned from efavirenz, the older HIV drug. So everybody was saying DTG is the way to go, so they were enrolling people on DTG. But then, although it was superior drug, we got so many complaints from patients. Patients were complaining around hyperglycemia, erectile dysfunction. So I was reading so many letters from patients in newspapers asking for guidance and saying, "Oh, this new drug, since I started it, I'm getting problems." So I kind of picked interest, and I happened to be working closely with somebody at the Ministry of Health in Uganda who's in charge of HIV treatment. And she was sharing with me the challenges. They were receiving a lot of reports around problems with DTG, but they had no research. They had no data. And the National Pharmacovigilance Center was saying, we don't have reports. We don't have ADR reports. But the patients were really feeling the impact of this drug and the side effects and the adverse events. So that's how I got interested, And fortunately, around that same time, Uppsala Monitoring Center was supporting the Consortium for Advanced Research Training in Africa, which funded my PhD. It was supporting researchers who are interested in pharmacovigilance research. So naturally, I got in touch with the National Pharmacovigilance Center in Uganda. So they supported our bid and we successfully got that research grant. So that's how I was launched into pharmacovigilance. Pharmacovigilance. So it was out of a problem, really. It was not that I trained as a specialist in this area.
So actually the topic that we are talking about today around the spontaneous adverse events reporting, that's actually what got you into pharmacovigilance from the beginning, looking at what patients were describing from their new HIV medications. And so this is in many ways the backbone of pharmacovigilance systems, the spontaneous reporting. And we often talk about the fundamental challenge of underreporting and the low proportion of events being reported. Do you think it would be fair to say that the quality of reports is an equally big challenge?
No, that's a fantastic question. Frederick, you're absolutely right. Of course, Uganda and many countries in Africa have underreporting, and I've seen studies which suggest that only 10% of adverse drug reactions are actually reported to the authorities. So in Uganda, we have that problem as well. However, what has happened in Uganda is we have benefited from so many interventions around piloting new reporting routes, such as the MedSafety app, which I participated in rolling out, reporting via WhatsApp. They even accept email ADR reports. But when I engaged the National Pharmacovigilance Center in Uganda, they told us, Henry, okay, now, initially we had a problem of underreporting, but now the volume of reports has increased, which is positive. However, the quality is now a challenge. There's no dosage of the person. When did the onset of the symptoms begin? And so all the details are sometimes missing, or you find like a significant number of ADR reports are not cannot be used for analysis. So that's why we launched into this research in the first place, because the NPC in Uganda thought this was a research problem they had, and they wanted to understand from the perspective of the health workers, from the perspective of the patients, what are your problems? Why are you giving us incomplete reports? Hence, this research which we conducted.
And that research is actually what we're going to focus on here today. This recent study of yours, where you and colleagues at the College of Health Sciences at Makerere University and the National Pharmacovigilance Center of the at the National Drug Authority, both in Kampala, Uganda, where you explored drivers and obstacles of data quality in adverse events reporting. You've already mentioned that it was a qualitative study, but I was wondering if you could go a little deeper into that.
Okay. Thank you. So first of all, as I mentioned earlier on, this study was commissioned by the National Drug Authority, or the National Pharmacovigilance Center in Uganda, and it was a research priority. All right. They wanted to understand why are we getting reports that are incomplete, that do not help us to analyze and therefore take regulatory decision making. So this was a qualitative study, meaning we conducted in-depth interviews with HIV clinicians. We conducted focus group discussions with patients, people who are living with HIV/AIDS. So what we did is we went to 12 HIV clinics across Uganda. So we made sure that the clinics we selected were kind of regionally representative. We got Northern Uganda, Southern Uganda, Eastern Uganda. And also with a certain level, we had a regional referral hospital at the various levels of service delivery. So we tried to have like a really representative sample.
So what did you find out with regards to obstacles and drivers?
No, actually, this study, in my opinion, was revealed many novel things, many new, interesting things that we didn't know. For example, we found that patients, first of all, deliberately underreport because they want to remain on effective HIV therapies. There's this super HIV drug called dolutegravir, and patients believe this drug is effective in viral load suppression. And so they have seen from their friends, when they report side effects, they say, I have erectile dysfunction, I have hyperglycemia, I have nausea, I have insomnia. Then the clinicians tend to kind of revert them to the old HIV drug. And the patient thought that this leads to kind of getting a medication that is not effective. So They deliberately underreport the severity of the ADRs they are suffering. So they don't give all the full extent of the ADRs, because they know when they give you the full details of how they are being impacted, how their vision is affected, how they can't sleep at night, then definitely, naturally, you'll say, no, we have to take you back to efavirenz, we have to take you to atanazava, another HIV drug. So patients are kind of tolerating the adverse drug reactions of DTG because they believe or they perceive this drug to be very effective. And from their judgment, they would rather suffer the ADRs, than lose an effective regimen, an effective medication.
That must be so important feedback for healthcare professionals to know that this is what patients are fearing.
Yeah. I think it was. That's number one. Number two, we found that there's a high level of herbal use, especially among HIV patients who are 50 years or older. Now, when they become older, also because of the medication itself, actually, it also leads to NCDs, non-communicable diseases, like diabetes, hypertension. And now in Uganda, HIV treatment is free to the user. The government provides treatment for HIV treatment, partly because also the US government used to support Uganda government to provide treatment free of care. Now, we have a challenge of these NCDs or non-communicable diseases like hypertension. So, although the government claims to offer treatment, patients tell us actually the hospitals don't have the drugs. They're not available. So when they go to a government hospital, they might tell them, we are out of stock. Please go to a private pharmacy and buy. And many of our people are very poor. So what they do then is they revert to natural remedies, because Africans had these herbal medicines for a long time and they were using them. Of course, there are challenges with that, but now many people are taking these drugs. So the clinicians told us, Henry, now this person tells you they have these problems, they have insomnia, they have neuropsychiatric problems. But when you ask them, what other drugs are you taking? They say, no other drug. Are you taking herbs? Yes, I'm taking herbs. Then they have a challenge doing causality assessment, linking DTG to these problems. So when they're filling these reports, that's another challenge on how to overcome it. Then the other challenge we found was that now, because Uganda has a high HIV burden, HIV clinics in Uganda are congested, there are long waiting times, there's a heavy workload. So the Uganda government and even the American government, because I was supporting it for a long time, they devised new approaches to HIV service delivery. And they're called differentiated service delivery models. So if you are virally suppressed, they in their judgment, you don't need to come to the facility every month for review, because you're very suppressed. So what they say, for we're going to give you a 6-month supply of HIV medication. You only come back at least twice a year. All right. So you go to the community or somebody can pick drugs on your behalf. The aim was to, first of all, reduce the burden of care on patients, to reduce transport and time spent at facilities, and also to decongest the health system. We found that now when it comes to reporting adverse drug reactions, now this arrangement is problematic. Because patients come back and then after 6 months, they have had all these, they have been enduring these adverse reactions. And we even found some actually die, For example, if you have hyperglycemia and it's uncontrolled for 3 months, it can lead to death. So they told us now this is a major problem. Although it was meant to ease the life of patients, when it comes to adverse drug reaction reporting, now it's becoming a problem, because now when a patient comes for after 6 months, they are telling you about this ADR they suffered, but then recalling events become problematic, because when you ask them, when did it begin? What symptom did you get? What drugs were you taking at the time? What other symptoms did you have? And then a patient can only give you bits and bits of information.
Yes.
So they don't give you a full picture that helps you to determine which other ADR is this, do a causality assessment. Besides patients, we also found that healthcare professionals also are part of the problem, actually. First of all, the health workers I talked to said they don't have incentive to report. They said they have been reporting. They don't get feedback from the National Pharmacovigilance Center. They told us that reporting is inconsequential. Whether you report ADRs or not, there's no feedback, first of all. Number two, you don't get any guidance on how to manage the patient. Basically, it's inconsequential from their perspective. All right. And that's why qualitative research is good because you understand somebody's psychology, somebody's understanding. And so that also affects the amount of information they provide on ADR reports, the seriousness with which they take ADR reports, the amount of detail they give in ADR report. So it's like a formality. So they will say, oh, this person came here, he had erectile dysfunction, it was for 2 weeks. And so they will skip so many parts of the ADR report and just submit it, because in their mind, whether they report or not, nothing's going to happen. All right. So health workers have developed kind of complacency. Now, that's another point. They have kind of we have submitted this paper for publication, and we have called it professional urgency, where the health worker now says, we know what DTG causes. I no longer have to report to the National Pharmacovigilance Center. If a patient comes to me, tells me he has hyperglycemia, I know that's DTG. If he tells me he has erectile dysfunction, I think probably that's DTG. If he tells me he has insomnia, he can't sleep, that's DTG. So what they told us, the clinicians no longer even bother to report to the National Pharmacovigilance Center, So that's a huge problem. They said, what I do, I manage the patient on my own. I either remove him from DTG, I take him to a furtherance, or I take another clinical decision. So I don't have to bother myself giving a well-detailed report to the NPC because I know the NPC will not guide me, it will not take any action. So also this situation where health workers manage these ADRs on their own is also, I think, a huge challenge, all right, a huge challenge. Then also we found some health system issues around laboratory infrastructure, even basic inputs for reagents to conduct studies, even basic things like liver function tests, glucometers for testing blood sugar, they are not available. For example, if a patient says I have frequent urination at night, I am wasting away, I don't know whether it's because of DTG, the clinician cannot even do a simple test for blood sugar because they lack glucometers, they lack basic test kits. If you go in rural Uganda, these are real problems. They're real problems for a clinician. So he may have a hunch that this is hyperglycemia, but they cannot even write it on the ADR report because he has not taken the mandatory 3 fasting blood glucose tests, to be able to say authoritatively that this is hyperglycemia or diabetes or whatever it is. So anyway, so we found that there are these issues of underreporting or incomplete information or inaccurate information are an interaction between patient-based factors, health workforce factors, health sim factors. So it's really a complex thing. It's not just a one-factor thing. There's an interaction in the factors, that contribute to incomplete documentation of ADRs.
Yes, that struck me as I was reading your paper, just the complexity of the challenges, the combination of some material challenges, communicative challenges, and also another challenge that was that you mentioned, that clinicians may also hesitate to report events out of fear that it may be due to a medication error. So someone would perhaps point their finger at them.
Oh yeah. They say when they report, they kind of invite scrutiny in their clinical decision making. So they think when they report, then they will say, oh, did you give the patient the right dosage? Did you guide them properly on how to take these drugs? For example, I'll give you an example. DTG is supposed to be taken in the morning, not at night. Some of the ADRs of insomnia are because patients are taking the drug at night, contrary to instructions. And so if you report, for example, insomnia, they will ask you, did you tell the patient that they have to take this drug in the morning? And then there's an anti-TB drug called isoniazid. You're supposed to put another additional drug to avoid the very toxic effects of the drug. I think called pyridoxine. There's a drug you have to add on. But at the beginning, clinicians were not providing that additional drug. So there was drug toxicity of TB drugs, So now you see, if a health worker reports that, then they think that they are going to bring into question their own competence as clinicians. So, it's an unfortunate situation.
I was also interested to see that in the paper you say that the majority of healthcare professionals in your study, they preferred to report via the WhatsApp route that you mentioned, but currently paper-based forms are still the dominant reporting form, reporting route. Is that right?
Yes, absolutely. That's a good question. Now, according to I think studies in Uganda that I've seen, published data shows that paper-based ADR forms are the dominant reporting tool. Okay, so that's number one. Now, what we did, we asked them what they preferred, what route, what platform they preferred to report, and the majority of them said WhatsApp. All right. And as I said, I've been involved in the rollout of MedSafety app, and I know these interventions that are ongoing. So, and what I asked them, why do you prefer WhatsApp? They said WhatsApp allows them to report in the way they want to report. There's a convenience, to give the level of detail they want. Number two, which is I think underestimated, is that they said also they are able to take a photo of the side of the symptom, of the ADR. So they can, for example, if a patient has jaundice or whatever it is, they can take a picture, if they have wasting, they can take a picture and share it on WhatsApp. All right. So number two is most medical doctors have smartphones actually, and many of them can afford internet. So they always have WhatsApp. At least the WhatsApp is not very expensive to maintain, even if internet charges are very expensive in Uganda. So they prefer to use WhatsApp. And, they told me two principal reasons. One is it's convenience, fast, quick. And also they know that their report has been received. Because, when you send a WhatsApp, it can show you what time it has been delivered and that has been received. So that's why they preferred WhatsApp, which again was an interesting finding, but we need more research to understand that.
I'm quite curious about this WhatsApp reporting. So how does it work? Is it just free text reporting from the clinician's side, or is it possible to have some kind of questions or prompts or forms that they fill in?
Now that's a good question. Again, now that's why I said that the NPC in Uganda has increased the volume of reports received. Now the WhatsApp is unstructured. It's people report like the way I send a WhatsApp to my girlfriend or, or to my boss or whatever. So you report in your own language, in your own. Again, that's what they prefer, which doesn't help so much when it comes to analysis now. You see, that means now you have sent to the NPC in Kampala, in Uganda, the capital, and then a data analyst has to clean the data and kind of enter it into a database to make it analyzable. You see? Again, that's why we are going into these issues of data quality, okay? The reports are coming in, but analyzing them is a challenge now, all right? So although they like WhatsApp, you receive so many WhatsApp, but you have to make the data analyzable. So you have to move from the data you have received to making it usable, to cleaning it and making it intelligible so that you can analyze it. Yeah. So those are some of the challenges of WhatsApp.
That is a very interesting point you raised there. I think that just there is a balance there in getting a lot of information, but with perhaps less structure or quality as well. It demands a lot more work from the assessor, or having more structured, strict information, but getting less of it because it demands more from the reporter. And I would be very curious to know how, well, when it comes to the completeness of a WhatsApp report, how that compares to the completeness of the paper forms.
Now in Uganda, they require a lot of detail. It's very, very elaborate. One, they have to give patient details, age, gender or sex, what condition they're suffering from. Then you have to give details on the drug, what's the batch number, who's the manufacturer, expiry date. Even the reporter themselves have to give details. I'm a clinician, I'm based in this hospital, in this district of Uganda, So it's very elaborate, and some of the health workers think the detail is too much. They think it's too much. They should reduce on the detail. Of course, that's from their perspective because they have heavy workloads. But again, if from the perspective of the Pharmacovigilance Center, they need data that can help them do causality assessment, that can help them analyze, and link ADRs to drugs. So their standards are, of course, higher, So it's a question of perspective, Yeah. But it's very clear what we have to. An ADR report has to have details on the patient, on the drug itself, and the person reporting.
Is it possible for patients as well to report side effects in Uganda?
Absolutely. I participated in the rollout of the Med Safety app, and I published a paper, I think, together with a colleague of mine in drug safety on the rollout of the Med Safety app. Now, the Med Safety app has been piloted in some hospitals across Uganda, and some patients have already uploaded it or downloaded it on their smartphones, so they have it. So patients have now been empowered to report. Also, I've been involved in a study where we had the peer support model where we are supporting peers to help the patients report, and we train them on how to use the Med Safety app. So the patients have now been kind of engaged, have been trained on how to use the Med Safety app, on how to report, and how to train their fellow patients to report using the Med Safety app. So patients do actually report. But also, number two is that the National Pharmacovigilance Center, which we call the National Drug Authority in Uganda, has hotlines for reporting side effects by anybody in the public. And if you go to a hospital, you go to some private pharmacies, there's always a hotline. There's advertised. There's always a poster. NDA, please, if you have a side effect, please send us an SMS, a text message to this number. Call this hotline. So even patients can report. Even caregivers can report. If your father is on hypertension medication or cancer medication and he has very severe adverse drug reactions, you can report to the National Drug Authority. So even patients have been empowered to report. Although I would say overall, almost 80% of the reports in Uganda are from healthcare professionals. So it's still much health worker dominated, although there are interventions to increase uptake by patients in reporting.
How have Ugandan authorities gone about marketing this patient side effect reporting? You mentioned posters at clinics, and have there been other public campaigns or efforts to spread the word?
First of all, I would say number one is there's little funding going to pharmacovigilance. That's number one. Even the National Pharmacovigilance Center, the budget they have is insufficient to meet their responsibility in the country, all right, on what they need to do. So Uganda government does not invest enough in pharmacovigilance, in engaging patients, in reporting, in training health workers. So even the NPC itself is under the budget is small for doing the mandate it has as a regulatory authority, which is part of the problem actually.
Yeah. So departing from your research and your experiences with limited resources, what do you think are the most important interventions or actions that a regulator or a PV center could do to foster or improve data quality and data quantity for incoming reports?
Okay, thank you for that question. Actually, number one is the clinicians told us that, Henry, the way the government can help us is, first of all, to increase the national guidance on likely adverse drug reactions. And they gave me an example. When they're rolling out DTG, this super HIV drug, they're telling me they were just dropping boxes of medicine. They just drop drugs and they tell you have to give, each patient has to take one tablet a day, and that's it. They didn't tell them that patients can get hyperglycemia, that they can get insomnia if they take this drug at night. So even national guidance has to improve. All right. And then number two, health worker. I think health workers need to be trained. They need to be sensitized, especially nurses, midwives, because in Uganda, unfortunately, we don't have enough doctors in the front line of HIV service delivery. So you have a lot of nurses, midwives who are giving HIV care, who don't have extensive clinical training. In fact, when I was doing this research, one nurse told me, Henry, I didn't know that they need this ADR report to do analysis and to make a decision at the National Pharmacovigilance Center. I didn't know that. So I was just filling a form. I didn't know. They didn't understand there is an input in a process to make a decision. So training of health workers, especially mid-cadre, the nurses and midwives, who are very important in Uganda. 80% of the health workforce in Uganda are nurses. So we need to focus on the mid-cadre, even in their training at the tertiary level, in their institutions of learning, to train them in pharmacovigilance. Then even patients need to be told, they need to report, and they should stop tolerating adverse drug reactions. They can be toxic, they can be fatal. They are, So anyway, there are many, and then also we have to invest in laboratories systems, in strengthening laboratory systems, in basic things, liver function tests, glucometers for testing blood sugar, test kits, basic things. We need to improve our supply chain for medical supplies across the country.
I wanted to ask also, Henry, a dramatic change from when you wrote the paper is the financial terms for receiving HIV treatment in Uganda due to recent termination of foreign funding programs. And you write in the paper that the United States PEPFAR has enabled the rolling out HIV treatment to over 1.4 million Ugandans. And also you mentioned that the reason for many people to take traditional herbal medicines, for instance, for diabetes or high blood pressure instead of prescribed medicines, is that they cannot afford the conventional medicines. And I just wanted to ask, what will happen now?
And also, for an excellent question, and it's very timely indeed. Now, Uganda has been very heavily dependent on the U.S. government, especially, even other donors, including, because the Global Fund is funded even by European countries like the UK, France, and other countries. But the U.S. has been funding, I think, up to almost 70% of HIV spending in Uganda. So when the new administration, the U.S. government came into place, they had different priorities, and they abruptly stopped HIV/AIDS. So there have been devastating impacts. It has caused confusion. It has already resulted in disruption in service delivery. Medical medicines are being given now. That's okay. The antiretrovirals are still available. But HIV care is a complex disease to manage. Now, like community outreach, where you go to people's households to ensure they are adhering. Those who are not coming to the clinics for review, you tell them, please come for review. For example, you have people called counselors, people who give you psychosocial support to strengthen your adherence. All those who are not funded, they are not on the Uganda government payroll. So they're being funded by the Americans. Those are no longer in position. We had HIV prevention interventions like PrEP, which is a pre-exposure prophylaxis, where, for example, sex workers who take this PrEP don't get HIV, even if they're exposed to the virus. Now, all this stopped because it was American funded. For services for gay community, LGBT community has also now stopped because the US government was funding what are called drop-in centers, special health facilities which are friendly, which are not, which don't discriminate, which don't judge them. So now my prediction is HIV is going to reemerge as a public health threat again. So unfortunately, this loss in funding is really going to have major impacts. And right now, it appears as though we are managing, but my research has already shown that after around 3 years, that's when you really know the full impacts. That's when you see community transmission going up, drug-resistant TB rising, deaths happening. So it will take time to know the true impact of loss of aid. So now the Uganda government has come in with some strategies. One, they have said they are going to because HIV clinics were kind of standalone because they were American funded, because they were paying additional health workforce. Now they have said ideally the HIV clinics should be integrated with general health services. That's number one. All right. So the Uganda government is going to replace some of the funding for especially antiretrovirals, which is a positive thing. So the president has even said publicly that the Uganda government, we are going to do all we can to replace the money the US government has been investing in procuring antiretrovirals. So which is positive. Then also we had an idea of a levy or a tax on soft drinks like soda in Uganda, which had been planned about 10 years ago, but was never implemented. It was called an AIDS Trust Fund. That also is going to be kickstarted, revived, to make sure that there's more domestic reliance for the national HIV response. And they are trying also to improve national health insurance, private health insurance, and also to see if the private sector can contribute to bridging the financing gap. So there are a number of strategies, but it's still a problem that we need to really fully grapple with.
we're nearing the end of the interview now, and I wanted to ask what's up next on your research agenda? What studies are you planning to go into now?
No, actually, so that's a good question. Now, before I did this study, I had several meetings with the National Pharmacovigilance Center in Uganda, with people like Helen Dagije, who is really a champion in pharmacovigilance. And they have a lot of research questions. Actually, they had so many research questions. We were only able, because of funding, to deal with the one of data quality. So I'll give you just a few examples of the questions that we have not answered yet. One, they were talking about the potential role of AI, all right? And they wanted us to do research both within the NDA, within healthcare professionals. They really have a lot of hope in the potential of AI to help with the causality assessments, in data analysis, big data, machine learning. So we need to do that research. We're also looking at how to synchronize these multiple reporting tools of MedSafety app, WhatsApp, email, to find a way of kind of synergies, because right now they are standalone and they're not speaking to each other, to see how to manage that. All right. We also need to do research on designing new ADR forms, because there's been feedback saying it's too detailed, it's the space not enough. We take this one out. I want this one. So the preferences of healthcare professionals, which again hasn't been done, and the NPC doesn't have funding to do that, unfortunately. So there's several questions. The thing, of course, to do is to source for funding in Uganda and abroad as well, of course.
I'm already looking forward to having you back in the studio, Henry. Those are very interesting questions you have there. Given the, let's say, unlimited resources, do you have a dream study or a dream research project?
I think I have a dream research project. For me, I think that my little research has shown me that patient-led reporting actually is ideally what we should push for. Patient-led reporting. For me, I think we need more research and working with patients on how they can report, train them how to recognize adverse drug reactions, on how they can report easily, they can be confident, how they can have peers supporting them. So for me, my research would be on how to strengthen patient-led reporting of ADRs, because even given the UMC funding I got for my study on DTG, I found that actually patients come up with more novel ADRs than health workers. I'll give you an example. We found that DTG causes sexual dysfunction, which was a novel finding. Now, before I talked to the patients, I had been all over Uganda, Northern Uganda, Eastern Uganda, thanks to funding from UMC. Talking to clinicians, nobody had ever mentioned that there is a problem of sexual dysfunction that is causing low libido, it's causing marriage split-ups. But when you talk to the patients, they give you new, unheard of problems, So that's why I personally think that I would do more research around patient-led interventions to enhance reporting of ADRs. So for me, that's my dream project.
Thank you so much, Henry. This has been a very inspiring interview. Thank you for your time. And as always, I learned a lot.
Okay. All right. And thank you, Frederick.
That's all for now. But if you'd like to learn more about Henry's work, we've put together some links for you in the episode show notes. Apart from the Drug Safety Matters podcast, we have our pharmacovigilance magazine, Uppsala Reports. Visit uppsalareports.org to stay up to date with news, research and trends in the field. And don't forget to subscribe to the newsletter for the latest articles. If you have any comments or suggestions for the podcast or the magazine, please feel free to reach out on Facebook, LinkedIn, Blue Sky or X. You can also visit our website to learn more about what we do to promote safer use of medicines and vaccines for everyone, everywhere. If you like the podcast, please subscribe to make sure you won't miss an episode, and spread the word so other listeners can find us too. For Drug Safety Matters, I'm Fredrik Broneus. Thanks for listening.